Good morning. Today I'm going to speak about morphology and function, clinical decision making. This is my financial disclosure. Primary open-angle glaucoma is characterized by loss of ganglion cell and fibers. Both structural and functional changes result from loss of retinal ganglion cells and their axon. The degree of structural and functional loss used to grade the likelihood and severity of glaucoma in clinical setting in large-scale clinical trials. And this is a glaucomatous patient. This is his optic disc. You can see here thinner rim with loss of ganglion cells. You can see here the loss of retinal nerve fiber layer. And this is his visual field. You can see here a superior nasal step. The extent of damage is often difficult to detect, and clinicians use different technology to try to identify the changes. However, it's not so easy. If you see this image, you can easily understand that if you have a loss of fiber in the inferior sector, you can have a defect in the superior sector of the visual field. And this is an image from the anatomy. Just to remember that from the fovea we have a bundle that go directly to the temporal part of the optic disc, while from the inferior and superior part of the retina, the fiber go to the superior and inferior part of the optic disc, and from the nasal part of the retina, all the fiber go to the nasal part of the disc. Here you can see how the distribution with a color map of the fiber in the optic disc. This is an image taken from a perimetry textbook in which you can observe a different type of visual field defect: superior paracentral scotoma, central scotoma, superior nasal step, superior arcade scotoma, and so on. And this type of defect can happen if you have a sufficient loss of ganglion cell in the retina. This is another image in which there is a different representation of the visual field defect. This is obtained by Humphrey visual field system, and you can see the gray scale and the probability scale. And here another step with a probability that this change is significant. This is this is a blind spot. This is a paracentral scotoma, altitudinal damage, temporal edge, and so on. This is an image taken from the Jost-Jonas optic nerve head classification that was obtained in a cross-sectional study. In this study, he analyzed a lot of optic disc with planimetry, and he observed that in normal healthy patient, the inferior area of the disc was greater than superior, than nasal and temporal. In glaucomatous patients, this distribution is changed, and in the first stage there is no difference in the area from the superior and inferior part of the disc. In the second stage we have a more serious loss of fiber in the temporal inferior area, sometimes can be in the superior temporal part of the disc. And in the third stage of this classification, we have a thinning of the temporal rim of the disc. In the fourth stage, we have a loss, complete loss of the rim in the temporal part of the disc, with the thinner of the nasal part. And in the fifth stage, we do not have any more rim in the disc. So I show you the visual field defect. I show you the glaucomatous change of the disc. So correlation between structure and function should not be so difficult, but it's not in this way. When we check an optic disc, we always have to think about if this optic disc is normal or abnormal. For instance, in the first image on your left, you see an healthy eye. You see very well defined retinal fiber layer all around the optic disc. You see very pinky and wide rim and a small excavation. In the image in the center, we have an hemorrhage in the inferotemporal sector. We have a thin rim, probably thinner in the inferior pole, together with some changes of the lamina cribrosi that you can see, peripapillary area in the temporal sector. And on the third image, there is a large disc with a large excavation, but the rim is well defined all around the disc. The excavation could be something abnormal or just a physiological change. Here an example, just to try to match this visual field to one of these optic discs. There is a superior paracentral scotoma with a superior nasal step. So we mainly look for a damage in the disc in the inferior part, and here you can easily find what we are looking for. And as here you can observe the nasal step with the different sensitivity between the superior part and the inferior part. So it is not easy to match visual field and optic disc, and sometimes you observe the disc that can appear with a very important damage, and the visual field has a damage but not so severe. In this study, we try to evaluate the accuracy of matching optic disc with a visual field. This is a multi-center study done in Europe, and we try to match stereo optic disc photograph of 40 healthy and 48 glaucomatous eyes to a visual field chosen from 4 options for disc. The 4 presented visual field included the corresponding one and 3 other visual fields varying in severity. (250) ophthalmologists were invited, and 109 accepted to do the study. The histogram shows you the number of the ophthalmologists that were invited and the number of the ophthalmologists that accepted the invitation for each different country. In this table you can observe the demographic of health subject and the patient with glaucoma. In this column you can observe the healthy subject characteristic, and here the glaucomatous patient split in 3 different subgroups based on the visual field damage: mild damage, moderate damage, and advanced damage. In this table we show you the accuracy, overall matching accuracy, and you can see that the accuracy was around 58.7, 59, and when we split the overall accuracy in specificity and sensitivity, we observed that the specificity was overall 76, and the sensitivity change, of course, based on the glaucomatous group that we choose. In the mild was very low, 30, 31, moderate around 51, and advanced were 76. Interesting is the result that the result from UK. In UK, the 22 patient, the ophthalmologists that performed the study were glaucomatous consult, and you can see that also for consult the accuracy was not so high, 68. Of course, the specificity was very high, 99, and here the sensitivity based on the visual field damage of the group, 35, 65, 80. So from here, obviously, you can observe that if the damage is very advanced, it's easier to classify, to match with a visual field. Ophthalmologists tend to overestimate the severity of the visual field damage, and you can observe here in this graph underestimate and overestimate, and you can see that for the three different levels we have a higher overestimation. Previous studies have reported that combining functional tests with structural tests can improve the diagnostic accuracy for glaucoma over using one test alone. Most of these research are based on the Humphrey visual field system, and the most famous structural function map was developed by Gary Eve using Humphrey perimetry. Here his map. This was obtained by Humphrey visual field, and this was obtained by the HRT machine. The optic discs were divided in 6 different sectors and matched with the retinal test point. This map provides a representation of the area of visual field that correlate with sector of the neuroretinal rim. In the second step, the same group tried to improve his correlation with this new map that was published in the Investigative in December 2012. But there are also some studies that analyze this program, and this is the study in which they try to obtain a structural function map. 88 healthy subjects were included in this study, and 150 glaucomatous patients were analyzed. This is a visual field that we obtain and the position of the tested point, and these are the 12 sectors of retinal nerve fiber that we obtain by OCT. And these are the correlation map that we obtain as correlation, structure and function correlation that we obtained. And we can observe that this, for instance, this area of the optic disc were well correlated with this area of the visual field, and this yellow part with this part of the visual field, and so on for each different sector. A different study was done and published on the eye, in which we analyzed the pointwise correlation between both 10-2 Humphrey visual field test and 24-2 Humphrey visual field test versus OCT data in open angle glaucoma patients. In this study, we found that the ganglion cell complex and the retinal nerve fiber thickness measurement were highlighted as the most promising candidate metric for glaucoma detection and monitoring glaucoma. Here are the results of this study. You can see two different types of images. The color image, that means the coefficient of correlation, darker means steeper, and the gray images, in which the dark color means significant. And on the right of the gray images you can see also the legends. So if in this slide you can see the correlation between both 10-2 and 24-2 with the ganglion cell complex, and you see strong correlation in the superior and inferior part of the visual field with the OCT values. Here the correlation are between both visual fields and retinal fiber layer thickness, and here the correlation between visual field and OCT for full retinal thickness and outer retinal thickness. And in this last image you can see the sectorial correlation between visual field and retinal fiber layer thickness. This is a typical perfect case in which patient has inferior retinal nerve fiber loss together with inferior ganglion cell complex loss and inferior choroid thinning. And if we test the visual field of the patient, we found a superior nasal step or arcuate visual field loss. And this, I'm said that is a perfect case because in the clinical practice it's very rare to find everything in the right position when we check patients. So structure function is a difficult relationship, and there are different reasons because this correlation is not so easy to find. Variation in anatomy among population is one reason. Another reason is the variation in function among the population. Fluctuation or noise of measurements. Variation in the method of assessment. Different measuring and different scaling system are the main reason because this correlation can be difficult. In the population, we know that there is a wide variability of disc size. Small disc large disc. Both are normal, but you can see here how crowded are the ganglion cells, and here how much space there is around the scleral canal. And in this graph you can observe that usually the mean disc area assessed by planimetry was 2.5 millimeter squares, which is glaucomatous. And again, you have to observe the vessel of the optic disc where they change direction, and we can observe that this small disc has a very thin rim. On the other hand, this large disc has a rim always present in all the sectors. Another example, perhaps a little more difficult. This is a medium-large disc. The rim is present in all the sectors. There is a large excavation. On the other hand, there is a small disc with almost no excavation, crowded ganglion cells, and if you perform a red free red light photograph, you can observe that no ganglion cells are present in the inferior part of the disc. And if you do perform visual field, you can observe an nasal step and arcuate superior sect defect. Sometimes there are some patients that has an optic disc that looks like glaucoma optic disc, but without detectable visual field abnormality. And this can happen because before to have a visual field damage, the patient must lose at least 20–30% of the ganglion cell. Another type of patient is a patient that has a glaucomatous visual field without detectable structure, and this happens in small disc as I show you before. So different type of glaucomatous optic nerve heads can have a different evolution of capping. For instance, focal ischemic and sclerotic optic disc can have a different clinical approach. And here you can see this is senile sclerotic optic disc, and this is a focal ischemic optic disc. And you can easily see the difference. Senile sclerotic or age-related atrophy type of primary open-angle glaucoma is characterized by normal size, normal optic disc shape, reduction of rim area, cap depth that appear shallow, cap shape sloping, rare disc hemorrhages, large peripapillary atrophy, relative rare localized defect, reduce the diameter of retinal artery, and IOP is often normal or slightly elevated. On the other hand, focal ischemic type of glaucoma, of primary open-angle glaucoma, is characterized of normal optic disc size and shape, reduced rim area, rim shape with rim notches, and the presence of cap depth with a medium or deep, and usually the shape is circular steep. Hemorrhages are often present, small peripapillary atrophy, visual field with often localized defect as retinal fiber layer defect, and also here retinal arteries are reduced. IOP is normal. So coming back to the previous images, semi-sclerotic ischemic optic disc with hemorrhages, with notching, with lamina cribrosa evident, parapapillary atrophy. Different, probably, these two types of glaucoma have different visual field damage. And this was also published by Nicolela and Drans in ophthalmology, that show that visual field were different in 4 subgroups of glaucoma. Another problem that you can find in this structure and function correlation is the optic disc margin. Sometimes it's very difficult to identify. Usually in planimetry or using ophthalmoscopy, you can identify optic disc margin as the termination of the Bruch membrane, or has a border tissue, or as anterior scleral canal opening. But in a recent study using OCT, rays and strotitis show a different termination of the Bruch membrane. So this could overestimate the rim area, creating a problem in the correlation that we are looking for. Here, what they found, the end of the Bruch membrane, and they introduced a new parameter, the minimum rim width, that this distance that was now calculated for all around the disc, and then calculated in the sector and globally, and can help the physician to obtain a better correlation with the visual field. Here is an example of the minimum rim width calculated with the Heidelberg spectralis, and you can observe here the sector in this part are abnormal. This is suspicious. That means that is borderline. It is not in the range of abnormalities, but neither in the range of normality. Overall, the minimum rim width in this sample is abnormal. This is another example in which we compare using OCT spectralis the minimum rim width with the retinal fiber layer thickness. In this case, they found a good agreement. Both are normal in all the sector calculated, and that means that it is in the normal range of the database. But from this data, we have to think that our clinical ability to define the disc margin is into question. No, I don't think that these new findings will change for the moment our way to judge optic disc using ophthalmoscopy. Another problem that we have Another problem could be the tilted optic nerve head, which the double hump pattern will be displaced a little bit, shift from the nasal to the temporal side. The superior temporal and the inferior temporal band will not fit the standard distribution of the sector. Another problem is the position of the fovea respect to the optic disc. It has been shown that fovea can be moved a little bit up and down. So this can create a different bundle fovea of temporal sector, and there is a different distribution of the retinal nerve fiber layer all around the optic disc. So depending on the position of the fovea, we have to recalculate the temporal sector, and from that we can organize to assess the superior and inferior sectors. So theoretically, when we look for structure and function correlation, we have to create a personal map taking in account optic disc size and shape, fovea to the disc angle, position on the raphe, and so on. We have seen until now the problem due to the anatomy, to the structure, but there is also some problem due to the visual field. So when we test vision, we have a different way to test. We have a visual acuity, contrast sensitivity, color vision, and so on. There's many other ways to assess the visual function. And we know that there are different type of fiber in our retina. But when we test a visual field, we just use white on white light, and we calculate the capacity of our eye to detect the difference between the background and the spot that we project on it. So what about all the other ganglion cells that are present in the retina? Another problem could be due to the stimulus sites. The stimulus sites, it's always the same during the test, the perimetric test, but we know that depending of the area that we are testing, there are different number of receptor and ganglion cells. So in the center part we will have more ganglion cells and receptor. In the periphery we will have less receptive cells and ganglion cells. So this could be another problem to when we are looking for structure function correlation. When we perform a visual field, we test a different point, and each point is positioned at a regular interval of 6 degrees, for instance, for the 24-2 visual field, 2 degrees when you test with a 10-2 visual field. However, there is a little correspondence between the distribution of the test points in the 24-2 visual field and the distribution of the retinal nerve fiber layer. Another problem that we have in the structure and function relation is a different scale used. We know that to assess an optic disc you can use a linear scale, while when you assess a visual field you use a logarithmic scale. So in this graph you can see that for the same change on the x-axis you can have a different change on the y-axis. You can see from the different color, red and blue on the y-axis. Could non-conventional perimetry help and improve the correlation? For the moment, there is we don't know. There is the possibility, but we also have to consider that a different perimetry could use different, could detect, assess different ganglion cells, so that could be a different problem. This is a matrix printout, and you can notice that this non-conventional perimetry is able to detect some superior change in this patient. There is some fluctuation, but at the end you can find a superior defect, and this is confirmed by LCT analysis, both for the ganglion cell complex and for the peripapillary retinal analysis. In conclusion, in early glaucoma, structural loss appear greater than functional loss. In more advanced disease, functions change at a greater rate than structure. In the future, more sensitive system to detect the ganglion cell number of function may have a different relationship between structure and function. Distribution of test location that better represent the distribution of retinal ganglion cells, and or a stimulus which is scaled by estimate of retinal ganglion receptive field density could help us to find a stronger structure-function correlation in the future. Thanks for your attention.